Senator Emeritus Professor Sir Henry Fraser, Deputy Principal of Cave Hill Campus, Professor Clive Landis, Canon Noel Burke, Chair of the Barbados Christian Council, and Mrs. Burke, Dr. Dexter James, CEO of the Queen Elizabeth Hospital, Dr. Carlos Chase, President of the Barbados Association of Medical Practitioners, colleagues and friends of the wider campus community, ladies and gentlemen, welcome to the Henry Fraser Lecture Theatre and to the second lecture in a year-long series being given by the Faculty of Medical Sciences of Cave Hill Campus in commemoration of the 50th anniversary of independence. I'm not sure how many of you know that the Faculty of Medical Sciences traces its origins back in Barbados to 1967, 1 year after independence. So next year we will be celebrating our 50th anniversary. The 1967 cohort was very small, about 6 or 7 students, and we're just the final year. In the 70s, it expanded the School of Clinical Medicine and Research with 2 years of teaching. And of course, in 2008, the full Faculty of Medical Sciences with all 5 years was established. Many of you might be aware of public lectures and research findings of the university, but not many of you might be fully aware that many of the consultants working in the Queen Elizabeth Hospital are University of West Indies staff, and of course many of the doctors that are trained and practicing in Barbados have been trained right here at Cave Hill campus. Before we go on, there are a couple housekeeping issues. Mobile phones should be turned to silent. I think I should do that as well. Hopefully nobody calls me before this finishes. We say silent because those of you who are technology savvy may want to pose questions to the speaker via Twitter before you forget them in the course of the presentation at hashtag hypertension at 50 at Cave Hill. And you could also send emails to kenneth.connell at cavehill.uwi.edu. That's Connell, C-O-N-N-E-L-L. I'm not sure if he's going to be answering these questions in the middle of the talk, but he certainly will we'll be able to answer them at the end. And there are emergency exits, which hopefully we won't have to use at the front. Okay. To introduce the speaker this evening is no other than Sir Henry Fraser, Emeritus Professor, former Dean of the Faculty of Medical Sciences, former Director of the Chronic Disease Research Center, and he lends the name to this lecture theatre. And just before Sir Henry comes up and introduces the speaker, just to let you know, I am Peter Adams, the current Dean of the faculty. Senator Sir Henry Fraser.
Thank you very much, Peter, and welcome everyone. It's wonderful to see a crowd this size who've come out to the second of the university's 50th anniversary lectures. And perhaps I can begin with a bit of marketing myself, Mr. Master of Ceremonies, because I'm going to conclude the lecture series on November the 8th with a lecture which I hope will fill every seat and the steps. And my lecture will be Healthcare in Barbados, a topic that we're busy discussing in town hall meetings. Healthcare in Barbados, the pestilential past, the problematic present, and future prospects. November the 8th. So you can put that in your diary, but there will be something every month to bring you out. And today's lecture is a very special one on hypertension, because I'm going to give you one statistic before I go on. 40% of Barbadians over 40 have high blood pressure. 50% of those over 50, that's half of us. And 60% of those over 60 have high blood pressure. So you can see the size of the problem. And I'm very happy to be here in, I'm tempted to call it my lecture theatre. And I'll tell you how that came about, you see. Because when Sir Hilary Beckles came to the Cave Hill campus as principal, and we had our first meeting together, he said, "Henry, why don't we have a full faculty of medicine in Barbados? Why do we have a tiny clinical school which costs $150,000 a year to train a medical student in a class of 21 or 22? And I said, "Principal, only you can answer that, because I've said that for years, that we should have one." So I was given the task of converting a tiny clinical school with 40 to 50 students into a full faculty, and that's why we train our students from the beginning for 5 years until they graduate, and then they do their internship, many of them at the Queen Elizabeth Hospital. And so I had a hand with my virtual architectural ambitions to assist the architect in designing this lecture theatre. And at the end of 9 years as dean, it is normal after 8 years of dean for a dean to have a sabbatical year in which he can re-engage with his research and writing. But at the end of 9 years as dean, I'd reached the grand age of 66, and so the principal said to me, "You can't have a sabbatical, but we'll call the lecture theatre after you." So it was a very cheap way of the university, which was then getting into the problems of financing that you've all heard about. It was a very cheap way of the university saving a dean's salary. But it gives me great pleasure to be introducing Dr. Connell, because by the time I retired, you see, we had to find a successor as dean, and we've had one successor as dean for 5 years, and Dr. Peter Adams has succeeded him. And so he took that role, and he is a member of the class of 86. And the class of 86 was a historic class, a brilliant class, and our dean is now a member of that brilliant class of 86 in Barbados. And Mr. Deputy Principal, Professor Clive Landis, it gives me great pleasure to be sharing this moment with him, because he succeeded me and Professor Hennis as the director of the Chronic Disease Research Centre, which was another of my babies. Now, I won't call Dr. Connell one of my babies, but he was one of my mentees, and he succeeded me as clinical pharmacologist. So a bit about Dr. Connell. First of all, you may not know this, but the name Kenneth and the name Connell has huge implications, because Kenneth is a Scottish name which means handsome. Take a bow, Dr. Connell. And the name Connell, or the Irish version O'Connell, which means the son of Connell, actually means a strong wolf. So do not interfere with Dr. Connell, because he is a handsome and strong wolf. He graduated MBBS medicine in the year 2000. So he's a true 21st century man. That was his medical qualification in 2000. And it was obvious as a medical student in our tutorials that he was going to be my successor as clinical pharmacologist, because he had a passion for how we use drugs. And that's been my career role, how to use drugs effectively. And he went on and became an internist. That means a specialist in internal medicine, dealing with the chronic diseases, the chronic disease epidemic in Barbados, which we have, the obesity, which leads to the high blood pressure and the diabetes, and they in turn leads to the strokes and the heart disease and the kidney failure. This whole range of chronic diseases that internists like Dr. Connell deal with. Of course, we have another chronic disease in Barbados that was publicized in the paper, I think it was this morning, called teething. Those who read the paper. And then there's the chronic disease that is very, very prevalent in governance and the civil service, called the Implementation Deficit Disorder, or IDD. That's another chronic disease that we have to deal with. I'm not sure if Dr. Connell is going to address either of those chronic diseases tonight, but he is certainly going to talk about high blood pressure, the most prevalent chronic disease in Barbados. He has come back after completing his PhD at King's College in London. And just a word about King's College. King's College was started in response to the University College, which I attended. University College in London was started by a free thinker called Jeremy Bentham, whose body remains, having been preserved in a showcase in the Great Hall of the University College. And this free thinker did not believe in God. And people were absolutely horrified but he had the money he could afford to start a very intellectually based university in 1826. And so people got together and said, we will start a college in the name of the king in answer to this godless university. So Kenneth went to this King's College to complete his PhD in mechanisms related to high blood pressure. He's come back to Barbados and he is a workaholic, and he is involved in all of the things that I used to do. He's the chair of the Caribbean Public Health Agency Hypertension Guidelines Committee of the Barbados Ministry of Health National Non-Communicable Disease Commission. He is involved in the drugs in the hospital, the Drug and Therapeutics Committee. He chairs the Specially Authorized Drug Committee, and he's become the youngest chair or governor for the American College of Physicians Caribbean chapter last year in 2015. So Dr. Connell is a workaholic, and he's taken over one of my babies, the Special Hypertension Clinic for difficult to treat high blood pressure. And I won't take another minute of his time because he's got so much to tell you about high blood pressure that you will take away and educate and inform all the other people who weren't able to make it this afternoon. Because our role in the university is not just to train medical students, but to inform our public, our entire country. That is the role of a university. And I'm going to, on that score, I just remembered something else that I'll be doing. If you read my Sunday Advocate column on page 9 next Sunday, you will discover what lactose intolerance is all about. Because 80 to 90% of all of us are lactose intolerant. And many older Barbadians think that Pine Hill milk is bad because it gives them diarrhea, because so many of us are lactose intolerant. Well, I have good news for you. The Pine Hills lactose-free milk is now back in production, and I bought 48 cartons of it this morning. So spread the word. Lactose intolerant people, that's 80% of us, your milk is now out there again. Dr. Connell, or should I say Mr. Handsome, please come to the podium.
Deputy Principal Professor Clive Landis, Dean of the Faculty of Medical Sciences, Dr. Peter Adams, fellow Deputy Deans in the audience, Canon Noel Burke and his wife, Mrs. Burke, Dr. Dexter James, CEO of the Queen Elizabeth Hospital, Mr. Howard Griffith, the President of the best Old Scholars Association, the Lodge School Old Scholars Association, and Chair of the Board of the Lodge School Old Scholars Association, Mr. Patterson Cheltenham, Dr. Carlos Chase, President of the Barbados Association of Medical Practitioners, colleagues and friends of the campus community, and fellow directors of the Heart and Stroke Foundation, ladies and gentlemen, good evening. Well, this is an exciting evening, not just because I get to speak about a topic that's very dear to my heart, although not affecting my heart, but I get to speak to you in the Henry Fraser Lecture Theatre. And having been introduced by Sir Henry, and having been declared now forever as handsome, I want to thank you personally for your disclaimer that whatever is said up here, regardless of how ridiculous it might sound, you take full responsibility. Hypertensive at 50, blood, salt, and tears. And those of you who have already started on Twitter, we're at hashtag hypertension at 50 at Cave Hill. I have no disclosures. If there are any members of the pharmaceutical company out there who want to donate some money so I have a disclosure the next presentation, feel free to do so. Well, we have a lot to be proud of as a nation. We have certainly written our name on history's page. We have excelled in sports, in athletics, in mind games like chess. We used to be good at cricket, I think. We used to be good at cricket, and the campus is answering on that as well. And of course, my all-time favorite, Rihanna, who is taking over the sound waves, and there's really no other artist out there but Rihanna. And we have had our challenges. We have been given the label as the amputation capital of the world, fairly or unfairly. We have this huge burden of hypertension, and This problem of glaucoma, the silent thief of sight, which my classmate and colleague Don Grosvenor is going to speak to next month. We still have the problem of HIV/AIDS, and of course the problem of type 2 diabetes, for which the university is currently engaged in research. So we have had our challenges. And our university has responded in a tangible measure. We have researched problems that are relevant to Barbados, including diabetes, hypertension, HIV, childhood obesity. We recently launched a campaign looking at Zika virus, sargassum seaweed. We have played our part as a university. And so I'm going to tell you several stories this evening, but my first story is about a text that I got this morning, actually, in the hypertension clinic at the hospital. Someone sent in a text to say, good luck this evening. They said, well, just in passing, when is UE going to make a big donation to the hospital? I was a bit reluctant at responding because I am aware that other institutions have made donations. This university, this Cayfield campus, has made a tangible contribution to Barbados because we are part of the fabric and history of this country. We have answered questions when we had problems of HIV/AIDS, which threatened our productivity. We have answered questions when we had problems with hypertension, which still threatens us. We have answered the problems of sargassum seaweed and as it threatens our tourism product. We are currently answering the economic challenges of our country. Our university does not make a one-off high deposit. We make a sustained deposit to the development of this country. And so I feel entirely comfortable tonight. Thank you. To declare, this university is not here to support Barbados at 50 years, but we will be here at 100 as well. So through strong partnerships, such as described with the hospital and the Chronic Disease Research Center that Professor Landis was head of, and now the Deputy Dean of Research, Dr. Lafayette Samuels, is currently head of, we have had our impact. And we've been part of the whole setting of standards. We haven't kept our research and our standards to ourselves in the Caribbean or even Barbados. We have contributed at the global stage. And rest assured that this governor is very vocal in Washington when it comes to issues concerning health of our country and of our people. A new threat is here, but it's an old new threat, the non-communicable diseases, including hypertension, cerebrovascular disease, as well as peripheral arterial disease. And it affects all of us. The collage of people who are here this evening really are all represented here, and I don't see any of the pediatric cases here. They're probably at home having low salt formula. But from the cradle, literally to the grave, cardiovascular diseases affect all of us. And in the audience, there is a relative, a spouse, a friend, or even yourself who might be currently having a non-communicable disease and living with it and coping with it. So the challenge is real. And according to WHO, on its current trajectory, 80%, if you think about this graph, it's alarming, 80% of the disease burden will be in low to middle income countries. And if you're trying to decide which category Barbados currently stands, I'm not going to answer that. But we're certainly low to middle income, and so it's affecting all of us, our productivity, and it's costing us. It's costing us a lot of money, and we don't have a lot of money, I am told. 60% of our drug budget, 60% of our drug budget of your taxpayers' money goes towards the treatment of hypertension. That's alarming, isn't it? I mean, hypertension isn't the only disease out there, except to me. Yet the control rates of hypertension are just only about 30% for patients on these drugs. Clearly, we're doing something wrong if we have so much money being spent, such relatively poor control. And so Barbados, as we celebrate our independence in grand style this year, we have a lot to consider moving forward as to how we will address the problem of hypertension and the NCDs. In fact, one past Prime Minister, now late Prime Minister, the Honorable David Thompson, suggested these words, and they stuck with me. And he said, and I quoted, "On their current trajectory, these diseases threaten to erase all of the gains made in our post-independent development." Can you imagine that? If we had a mosquito-borne virus approaching Barbados that threatened to remove all the gains we gained post-independence, none of you would be here. You'd be home covered in sheets or DEET. But yet we have a chronic disease that's doing so, and still there is some degree of comfort. These chronic diseases are like three musketeers. I often tell the students that, and sometimes they listen to me, that these musketeers, once you find one of them, look for the others. They're lingering there, and I use the analogy to patients as well. Hypertension, diabetes, and high cholesterol, they work as a deadly threesome. And healthcare professionals are obliged, once they detect one, to look for the other two. And don't just look for the other two on the initial visit, but keep looking because they're out there. But hypertension stands alone because of its impact on health. And it has, of all the NCDs, of all the cardiovascular disease risk factors, the most significant impact on health. And hence it's called the silent killer. How many of you knew it was called the silent killer? So it's not so silent after all. Now, without even getting into the science of it all, I think everyone in this room appreciates that high blood pressure is bad. You may not even know the numbers. I say to some of my patients who I see in the hypertension clinic, "What's your normal blood pressure meant to be?" I don't know. Is high blood pressure bad for you? Yes. So we know it's bad for you, whether you know the absolute values or not. I've never had a patient in our clinic, Henry, say to me, "You know, I'm really concerned that my pressure is becoming too normal and too low. I want it to get higher because I would feel better if I had a higher pressure." People don't respond that way. They think that high blood pressure is bad. And the higher it is, the higher the risk. But just so this audience is unique, I'm going to leave you with some numbers. The 140 on 90, which are the numbers currently used by most societies to define the hypertension phenomenon. And you can use any of the societies, whether it's the British Hypertension Society, the American College of Physicians, which of course I have a disclaimer, I have a bias there, so I have admitted my disclosure. The Canadian Society, coincidentally, that I've used here, all of them have these categories where they try to categorize you as normal, less than 120 on 80, pre-hypertension, whatever that means, stage 1 hypertension that is high risk, and I guess red is getting redder here, and stage 2, which they've called very high risk. And I get the impression, the idea behind this was that physicians should think that, well, very high risk is very bad, you need to be more aggressive. High risk is bad, moderate risk, not as bad, and low risk, you can relax. And so the pre-hypertension category of moderate risk becomes a challenge because what do you say to a patient who is pre-hypertensive, who has a touch of sugar, because no person with diabetes ever has diabetes, I just have a touch of sugar, and a cholesterol that's slightly off. So you're slightly moderate to normal. But pre-hypertension is certainly a trigger to healthcare professionals. And I'm posing this evening to you as the audience, the patients, to take more seriously these blood pressure numbers. 120 to 139, the top number, and the bottom number of 80 to 89. As a PhD student in my first year, I had the honor of delivering the Preclinical lecture at Cambridge. And the Preclinical lecture is one of those lectures where you're fiercely attacked by your colleagues. And I'm not going to say that the degree of attack is probably higher if you're coming from the Caribbean. but you're fiercely attacked. And one of my colleagues, when I said to him, well, hypertension has a J-shaped curve, the response was, well, don't be ridiculous. This J-shaped phenomenon is really, it hasn't been proven. And I said to him, well, show me the patient that has a blood pressure of 0 or 20 that you've had a consultation with. And he looked at me. 40, 50 systolic. And as we know, as our blood pressure falls below a certain threshold, your risk increases. So it's not that I can say to you, get your blood pressure to 0. All of us, I suppose, will get our blood pressure to 0 eventually, but don't do it intentionally with medication. So these shades and colors might represent a black and white difference. And in hypertension, if you look at most of the modern guidelines, you see that there are descriptors of race. And you're really only in one ethnic group. You're either black or you're non-black. There are no shades in between there. And I'm always curious at that. You're either black or non-black. You're not high brown or mixed or Douglas. You're black or non-black. And there's a strategic reason for that. Hypertension affects this race. Black Americans develop hypertension earlier. They have a high prevalence of hypertension in this group. And organ damage occurs at an exponential rate. There's a 320% increase in end-stage renal disease or chronic kidney disease, an 80% higher stroke mortality rate, and a 50% higher heart disease rate. So this is really our disease that's affecting us. And then, of course, the next question you ask is, why is there this difference? Well, the reasons, depending on who you ask, might be crystal clear, or they might be as clear as mud. And although healthcare professionals, like doctors especially, and I'm not going to wear my doctor cap this evening intentionally, we claim to you, yeah, we have this thing all under control. Really, our thought processes during many consultations look exactly like this. We are confused about the mechanism. We are confused sometimes about which is the best drug to choose. Hopefully, none of us are lost. But we become very perplexed at what's the next step to go. Where's the next step to go in the management? Well, the answer is in the food, isn't it? It's what we eat. I mean, that's easy to blame. I'm not going to call any fast food restaurants because they know me well. But it's all in the food. And so for those of you who are having salt and chips, and some of my colleagues like salt and chips, or who are having the high-fat meals, and the photo of the person, the face of the person in the photo is intentionally obscured, who are sitting in a cushion, in a couch, having popcorn. I like popcorn. Watching television, and really only the physical activity occurring is at the thumb, changing channels. And I get annoyed when the remote control isn't working. But doc, it's only a pinch of salt, isn't it? It's just a pinch of salt. How much is a pinch of salt really going to do to me? Well, first of all, you have so many varieties. You have the expensive pink Himalayan salt. I can't afford that. The dean can afford that, but I can't. You have the rock salt that's crushed, low salt. Have any of you ever read the food label on low salt? There's quite a lot of salt, but it's low, and low is in red, so it must be good. And then there's MSG. How many of you are Chinese food fans? Oh, every medical student is going to raise their hand. The MSG has sodium, so you've got to watch out for that. Now, here's a story, and I recognize that Canon Burke is in the audience, so I'll be very careful how I say this story. I once saw a patient, actually I saw her about 2 years ago. She came to me. We had a long conversation about salt and cutting down salt and not lime and salting and not having. She said she'd have 1.5 pinches, however you calculate half a pinch. But then there was this declaration which shocked me. She said, well, doc, with this container of salt, nothing looking like this. She said, I now have holy salt. I took my salt because you said it was bad, and I took it to the priest. And I got my salt blessed. And so my salt is not ordinary salt, it's blessed salt. And from my experience in dealing with patients and religion and religious belief, I said to her, well, that's admirable, but you should consider the next time you go to the pastor, take your tablets and have them blessed. And then take the tablets and maybe they'll work better to counteract the better salt. Salt is in everything. It's in everything. We cannot have a no-salt diet unless you're having distilled water. It's in processed foods. In fact, 77%, almost 80% of the salt consumed, and the CDRC has done some work on this, is in processed and restaurant foods. 12% is naturally occurring, but of course, nature is good for you, right? So it's natural. Your kidneys can't tell the difference. It's salt. While eating, we add salt. At one tertiary care hospital in Martindale's Road, I will not call the name, there are salt shakers, or there were salt shakers on the restaurant table in the cafeteria. And one OCD consultant wrote a 3-page letter about salt and how bad it was, including diagrams, to the restaurant owner saying, could you remove the salt from your table and make it at least more difficult for people to get to it? And I use this from personal experience. As a PhD student at King's in Guy's Hospital, and this is embarrassing, in the floor of the hospital is a McDonald's. That's why the medical student appraisal ratings are so high. There's a McDonald's right in the floor. Maybe we should try that at Cave Hill. What McDonald's did in my second year was they removed the salt sachets from the condiments, and you had to go to the cashier to ask for salt. Think about it. You've just left the line. You have your food, you're ready to eat, no salt. You're not going to get back up to go to the cashier for salt. I can guarantee you that, unless you really want that salt. And then what about labels? Well, labels are very interesting things. So no sodium added. Now here's how the food industry tries to trick you. Literally means that there's no sodium added. It doesn't tell you anything about the sodium that was there before. The restaurant and the food manufacturers are clever. What about 25% less sodium? Well, if you're already starting off at high sodium, 25% less sodium may still take you above the 1,500 milligrams that you're allowed as an adult Black Caribbean person. And here are some recommendations from various colleges. The American Heart Association is probably the one that I refer to more often. And they recommend 1,500, interestingly, in everyone, so Black or non-Black. The World Health Organization recommends 2,000. I guess you're going to ask me, well, practically, what does this really mean? I don't do milligrams kind of thing. Well, it really equates to just about 3/4 of a teaspoon. That's not a lot of salt as your limit. It's a couple pinches of salt. And when you consider you're already consuming the excess in the processed foods that you're eating, by adding salt, you're really topping your limit. Breads and rolls, cold cuts, cured meats, none of this is really Barbadian, and this is the independence lecture. Pizza, I'll get to some local stuff. Soups are local with pigtail. I like pigtail, that's my second disclaimer, Rihanna and pigtails. Sandwiches, cheese. Cheese is loaded with salt. Mixed pasta dishes that are easy to prepare if you're a microwave person. And salty snacks. And so the USDA sodium recommendation of 1,500 milligrams per day, many of you will say, is unrealistic at best in a developing country like the United States. But what about Barbados? Well, here's the Connell's 101 on how to deal with local salt. Start to cut slowly. So don't leave your doctor's office the next day thinking, I'm going to go from 3,000 milligrams of sodium to 0 with prayer. And I'm going to get there tomorrow. I recommend to patients initially to choose salty and salt-free days. Some patients at their 3-month appointment claim they've only managed to have one salt-free day in 3 months. I appreciate that that's a challenge, but I give them credit and I praise them for every salt-free day that they've had. And they've had salty days as well, where one old lady said to me, well, you know, Sunday meal is just not going to go without the lime and salt. You can do whatever you want to do to me during the week. Sunday, the chicken is getting lime and salt. What about balancing meals like fish cakes and pudding and sauce? I have a third disclaimer for pudding and sauce, and some of you in the audience may know why. Thank you for joining me, Mom. And then record your progress. With all the salt reduction, it makes no sense making all this effort to reduce salt and not even having a conversation with your doctor about it. And so every patient entering my office and also in the hypertension clinic, they kind of know how the story is going to go. He's going to meet me. He's going to ask me for my blood pressure diary. He's going to tell me I've lost some weight, although I've gained some weight. He's going to say, you're looking a lot better since the last time I saw you. And he's going to mention salt. And just in case I forgot to mention salt, some of them will say to me, well, what about the salt? I say, oh, how are you doing about your salt? Oh, I thought you would never ask. Well, I have managed only to have fish cakes once this month. That's amazing. You had fish cakes only once in 32 days the last time I saw you. So that's an improvement. You've done better. So the key point is talk to your doctor about salt. This isn't a hidden conversation with you and your chef. We want to know how your salt is doing. And we enjoy talking about stuff like that. So there's insensible loss of both water and sodium. The medical students know this diagram in the physiology very well. This is where they say yes. And therefore, as water is lost, sodium is also lost. Or more correctly, as sodium is lost, water is lost. And so comes excuse 493 to consume salt. I sweat a lot, so I have to take the salt. Well, many people do sweat a lot, and we do lose a lot of sodium. In fact, how many of you in here are marathon runners? No one. So none of you really have this excuse. If you run a marathon and you're repleting with just water, then you are likely to develop a fall in your serum sodium. That's dangerous, and that's called a fancy name in medicine, exercise-induced hyponatremia, or exercise-induced low sodium. But you've just admitted, you see, that none of you are marathon runners, so you don't need the extra salt. We lose it in our tears. Yes, salt is lost in tears as well. So don't go home and cry about it tonight, but you're losing some salt in your tears. And tears, as you saw in the title of my presentation, has some salient implication. A poor choice of words, but to tonight's presentation. As a people, we have had a lot of tears of joy. And we have Barack Obama, who is either black or non-black. And we have athletes that have won great accomplishments. I forgot to put the Rihanna slide in here, but picture Rihanna somewhere on this slide, tears of joy. And in our history, we have had tears of sorrow as well. This introduces another theory about hypertension in black people. And many of you are familiar with this triangle and the post-transatlantic slave trade. And so the Grimm's hypothesis emerged that somehow this ethnic difference in blood pressure relates to our history of slavery and post-slavery, and we've inherited these genes that somehow make us more hypertensive. In fact, I presented this in 2013 at the invitation of the then principal, now vice chancellor, at a reparations conference in Antigua, and I titled it "The Salty Truth: Persecution to Pressure." The slavery hypothesis proposed by Wilson and Grimm as it says there, proposed that African Americans possess genetic predisposition for life-threatening elevated blood pressure that was a consequence of intense selection. Now, picture it. You have all of these black slaves leaving Africa under not the most humane conditions, vomiting, diarrhea, various viral illnesses. This is the hypothesis in any case. And then they're brought to the Caribbean where they're not in barely tolerable AC conditions as you are here in the Henry Fraser Lecture Theatre, but they're out in the field working hard and sweat, right? So sweat means you lose salt. And also I'm told that salt was very expensive then, and so you are unlikely to get a salty meal if you were a slave. So if you could hang on to all of your sodium, well, that's a big advantage. I mean, you could then survive and pass your genes on to another generation. And Grimm's hypothesis got quite popular and still is quite popular in some circles. But like any hypothesis, and as I say to the students every day, and sometimes they listen, holes in the hypothesis exist. The holes in any hypothesis exist. And so, though salt retention is more prevalent in black Africans in diaspora, salt sensitivity is not in any means unique. And I should make a distinction here. The salt sensitivity has nothing to do with the amount of salt you consume. You could be on a low salt diet, a no salt diet, a 25% reduced salt diet, a blessed salt diet. You're salt sensitive because your kidneys are retaining all of it, and they're hanging on to it because of a genetic predisposition. The other hole in the theory is, of course, that the degree of salt loss is insignificant, or was insignificant, to really contribute a selection pressure, those of you who are into genetics and selection, to develop salt sensitivity. We now know that genetic mapping has occurred for a lot of these genes, these candidate genes. Some of them are related to sodium channels, and the students are going to say in the distal convoluted tubule. You were primed and you're still not answering. And others are related to substances that regulate salt, that are not directly in the kidney at all, such as nitric oxide, a substance that keeps all of our arteries healthy, but it helps us to get rid of sodium by mechanisms. So I would best describe hypertension really as a polygenic in origin, with varying degrees of environmental factors influencing the outcome within a particular race. But suffice to say that in the United Kingdom, although 10% of non-black people are salt sensitive, more than 50% of black people in the United Kingdom are salt sensitive. So there is certainly an ethnic difference, regardless of the genetic impact or influence and the environmental influence. And this probably does occur from the cradle, because black arteries are thicker. This is a test I used during my PhD studies, and it involves scanning the artery in the neck, the large artery called the carotid artery. And what I was interested in measuring, if I can get it on the screen, is this measurement here called the intima media. Suffice to say, the thicker that is, the thicker your arteries are, and it's thought to represent what's happening throughout the entire body. As early as in childhood, Winkop showed in stroke in 2012, there is an ethnic difference occurring there, long before we have been exposed to decades of salt. So there's possibly an inherent genetic difference or ethnic difference unrelated to hypertension. Hypertension causes stiffness. And in the hypertension clinic, when I first used to say this statement, the men will all look at me and smile and say, I want to be hypertensive till I die. It causes arterial stiffness. And so stiff arteries that are less compliant predispose you to several things like stroke and heart attacks. And this is one marker of arterial stiffness, pulse wave velocity. I promise you I will not make this scientific, because this isn't for the doctors in the audience at all. But certainly, pulse wave velocity changes and increases, and you can almost see that there's a clear difference between black, which is the black bar, and white. And it's statistically significant in African American versus European subjects. And these are not adult subjects, but they're in teenagehood and kids. So there's so many factors that are influencing hypertension, a wise man once said. But we have such little time to discuss them. And therefore, blood, salt, and tears, and our genes may all be acting against us to various degrees. Clinicians, physiologists, and scientists we've always been fascinated with blood pressure, always, from the beginning of time. In fact, we went to great lengths to measure blood pressure. So we took a horse. I am presuming that this horse must have been sedated or exsanguinated to some extent, that it just was lying there. It probably was not going to be this cooperative if it was well. And then we placed the manometer, and we tried to measure the blood pressure. Now, for those of you who go to your doctor and say, I can't wear this cuff because it's uncomfortable, this is a lot more uncomfortable. And I can almost guarantee you that this patient probably did not survive the measurement of his blood pressure. And through that, or past that, we then had case songs or carrot cough songs, where we use devices such as the mercury device, which allows you to measure blood pressure by inflating up the cuff and listening for these case songs. And listening in a very noisy clinic. And listening with a patient that's talking. And for a doctor that's really not paying a lot of attention, but thinks he hears when the song has stopped, as opposed to become muffled, but's not sure, so as Adams et al. Might say, is rounding up or down and saying, well, it's 120 on 80. Many of you have probably looked at the foot charts of patients on the wards of several hospitals. I'm not going to be selective. And I'm always curious at how the blood pressure is always 120 on 80 or 140 on 90 occasionally, but there's never any measurement in between. And I think, wow, these nurses must be really well calibrated. Even their hearing is in sync. And they get it the same. The blood pressure is static. I mean, we really should publish this, because the blood pressures of our patients, it isn't changing. And then you have the more sophisticated ones coming to technology and telemetry, like the Omron 7 series that's shown here, which uses smart technology to detect a pulse. Okay, yeah, the cuff still gets tight, but it's at the press of a button. You don't have to inflate. Many of you own these devices here, and I see some of my patients here nodding their heads. The important thing here is that you don't need a physician. The guardian of health, the master of blood pressure measurement, lowers voice for effect. You don't need the physician, right? You can do this at home. I mean, you can slip this cuff on easily at home. Some of my patients say, I'm not even up. I just slip off the bed and I just put the cuff on, and the cuff wakes me up. Because you said to take it first thing in the morning before I do anything else. So they do it first thing in the morning, and they record it. But of course you see a real problem here, because unlike diabetes, its close friend, one of the Muskateers, and cholesterol, hypertension is really a rapidly moving target. And so I got a call at 6:30 a.m. from one of my patients. She said to me, I could tell she's very anxious on the phone. She said, I just did my blood pressure, and it was high. Now, how high was it? It was 150 on 90. She said, okay, well, that's high. But no, but then I took it again, and it was higher. How high was it? It was 160 on 100. I said, okay. And then I took it again, and this continued until she said, and then I had a headache, and the blood pressure was bursting my arteries. And now I'm calling you, so what should I do? And I said to her, you should put your blood pressure machine away. You've done your 2 readings, forget about it. And you should repeat those readings in the evening, because I'm not really that interested in what those exact readings are. I am more interested in a trend. She said, Well, you think my blood pressure might be going up because I was worried? I said, well, that's a possibility. So you see, you could be worried about your blood sugar reading, but it's not going to change. If you're worried about your blood pressure, it's going to keep going up, and you're going to worry more. So we have a problem. We have a big problem. We're really shooting at a moving target. And then there's the office versus out of the office. I chose this photograph intentionally because it looks so clinical. It looks so regimental. It looks like my private office. And it's a gentleman sitting he's sitting squarely with his arms, his shoulders back, his arm is supported. Both feet are on the ground, so his knees are not crossed. Although, if you want to cheat and you really like to cross your legs, you can cross at the ankles, but not at the knees, because that does affect your blood pressure. And he's sitting. And he's probably going to have a blood pressure done by a healthcare professional. And on the right, a patient who's sitting at home, we don't know whether his legs are crossed or not. He looks a bit more perplexed, though, but he's taking his blood pressure using an automated device. And these are the two settings, really, that you can do a pressure. But if you think that all these things don't make a difference, well, here are some numbers. If you take it on a full bladder, your blood pressure can vary as much as 10 to 15 millimeters. If you have an unsupported back, so you shouldn't be taking home readings on a stool. If your feet are unsupported, that does make a slight difference, and crossing the legs does make a slight difference as well. Cuff over clothing. Now, I know most of the home monitors state that you can put them over light clothing and they're calibrated for that, but you shouldn't certainly be wearing a jacket as I am and doing your blood pressure. And it makes it higher, so it's not going to make it look better. The unsupported arm varies about 10 millimeters, and then conversation can change it as much as 10 to 15. If you're really animated, then it can make it even higher. And I often have patients say to me during the consultation as they bring their monitors in, and they kind of know that I'm monitoring them, how they're taking it. I say, so, how's your husband going? And they say, shh. And they don't want to speak during the reading. And then there's an app for that, of course. You have these fancy devices. Here's a great opportunity to be on your smartphone during the consultation, because you can monitor the blood pressures and display these readings to your doctor. You know, you can come to the office with this. And one of my 76-year-old patients, she said to me, you know, I went out there and I got one of those computer phones just so I could take some readings for you. She has two apps on it, the blood pressure app and the Read My Bible app. And she takes her blood pressure. She can't figure out how to get the graphs come up, but I work through that with her, and we have a discussion during the consultation. It's a change in consultation skills, which is Dr. Adams' forte, but introducing technology into the consultation can initially be a barrier, especially for a patient who isn't forewarned. And a doctor who is looking at you with a smartphone and looking at your smartphone, but with time, I can tell you, people get quite accustomed to it. And the technology is not being static at all. It's fast and furious, and you can use your finger now over the sensor or the light of your iPhone. I'm not sure if it works for other non-iPhone devices, but on the finger of your iPhone, it can calculate your blood pressure. Now, I'm not going to tell you how accurate it does that, but I can tell you, though, it is possible. It is possible. What it's measuring is the arterial waveform, and using a calibration method, it's actually calculating your blood pressure from the root of the aorta using something called a transfer function. So it's not completely crazy. And then if you think that hypertension is complex and perplexing, and sometimes I do, there are four categories. There's mask hypertension, where the blood pressure in the office is low, but the blood pressure outside of the office is high. Who do you think are at risk for that? Doctors. Yeah, we are more comfortable in the office. And so we are most likely to be misdiagnosed if we see a doctor to have our blood pressure checked. Sustained hypertension, where it's up in or out of the office, And then, of course, this white coat hypertension. I feel kind of weird without my white coat tonight, but I'm wearing a coat, so that's fine. And white coat hypertension is a serious thing because the blood pressure is artificially elevated in a doctor's office. So we have another problem. Not only is this a moving target, but now you have a setting that really is not ideal for measurement of a blood pressure. The office. The same place that you're going for diagnosis is not the ideal setting to measure blood pressure. How do you get away from it? Well, here's one way you could do. You could do a 24-hour monitor. You could put a cuff on and read your blood pressure. You don't have to keep pressing it for 24 hours. It's programmed. It takes a blood pressure every 15 to 20 minutes. Yes, every 15 to 20 minutes. And at night, it does it every half an hour. And you can chart all of that, or it's charted. It's in the software. And we can see your blood pressure profile. And that's like an echo to a cardiologist, really, looking at a blood pressure profile to a hypertension specialist. We like to look at these things because we can dissect them. Here's what a profile looks like, and I'm not going to go into it. Suffice to say that although the British Hypertension Society has suggested that hypertension in all newly diagnosed hypertensive patients have a 24-hour monitor, I think it is unrealistic for a small island developing state to insist on that. So I limit 24-hour monitoring to hypertension in special groups, such as hypertension in the elderly or in the very old, hypertension in young people less than 30, as well as hypertension in pregnancy. Of course, I use a 24-hour monitor because I'm a bit more worried about how low blood pressures are going as well because of the placenta. If there is organ damage and the blood pressure isn't as bad as the organ damage suggests, then I also do a 24-hour blood pressure. And any patient that comes in with strange symptoms of dizziness, fatigue, but the home readings look normal, then I'm going to do a 24-hour monitor as well, because I'm looking for periods where the blood pressure has fallen too low. But it's not the most convenient test at all. Any of you ever worn a 24-hour monitor? I have. I slept through it. I also slept through 2 hurricanes. But so it takes readings every 15 to 30 minutes. Some readings are lost because sometimes you're twisting during sleep. One patient said to me he was twisting for 24 hours and got no readings for the entire 24-hour period. Well, technically speaking, three 24-hour blood pressure readings are desired. So 2 work days and 1 weekend. And we're meant to look at, so it's even more cumbersome. And then how do I take a shower, doc? That's always the question. How do I take a shower? Take the cuff off. Do not go in the shower with the cuff on. Take it off. You have half an hour to do it. Unless you really want to have one of these long showers, you can get it all done in 30 minutes. The interns in the audience know you can actually get it done in 7. I mastered it to the fine art of 5. So home blood pressure monitoring is really an alternative that's convenient. It's cost effective. The cost of some of these 24-hour monitors can go up to 350 Barbados. It's more accessible because these monitors are all out there, and I'll come to that. You really have, technically speaking, a longer observation period because you're observing over days and weeks, and although you're not getting as many readings in each 24-hour. And of course, Dr. Adams would want me to say it's more patient-centered. It's a device that patients can say, this is my device, not yours. And I'm going to give you the readings. And so patients coming to the hypertension clinic sometimes become alarmed. They're coming to a hypertension clinic and they're not getting their blood pressure done. And it's a signal that myself and the nurses send into them. We're not really interested in what your readings are in this clinic. We want to see what your home readings are. And they get fiercely competitive in the waiting area. Well, look at my sheet. Well, what were you doing at 2 a.m. there? Anyway. So here's Connell's HB, Home Blood Pressure Monitoring 101. Get a reliable monitor and discuss this with your doctor. Take readings for at least a week before your visit. We know this is a doctor's disclaimer. We know you're not doing this for the whole 3 months between visits, but at least a week before the visit. We don't feel bad if you lie to us and tell us, I did it for 3 months, it's just that I brought this week. But do 2 pairs of readings, so 2 in the morning and 2 in the evening, record them all in your smartphone, or on what one patient said to me, his smart sheet, which is pen and paper. Just record them. If you're going to take the readings, and I never thought I would have to say this to patients, and even some of my colleagues, if you're going to take the readings, record them. It makes no sense taking it and then come to the office and say, I get like around 140-ish, plus or minus 10-ish on some days. Record them. And then if you go make the effort of recording them, bring the recordings to the consultation. Don't keep them at home. It's not a secret. Whatever notes you have written, you can take them out and just show us the readings. And have a constructive conversation with your doctor about the readings that you've obtained and the trends that you're seeing. And so a lot of press has happened in the last couple of days as the Queen Elizabeth Hospital, donated by the Heart and Stroke Foundation of Barbados, and a generous donation by CIBC First Caribbean of 45 home blood pressure monitors. And I want you to applaud First Caribbean for that donation. You're now my favorite bank. And what this means is that monitors can now be given to patients in the clinic who otherwise could not afford it. So you don't have the excuse, I couldn't afford the monitor because I had to see the Rihanna concert. You can get your monitor in the clinic. We write your prescription, you go over to the Heart and Stroke Foundation, and you get your high-tech Omron 7 series with Bluetooth capability. So you can do whatever you want to do with it. And it comes, it's what I call the couples monitor, because it stores 2 sets of readings. So lots of couples use it because the readings don't get mixed up. So I'm going to move away from home blood pressure monitoring and the logistics of taking a reading and move into, in the final set of my presentation, to the clinic. How can we strengthen health systems? Because doctors are very good at blaming patients. They're never going to tell you to your face, but we blame you for a lot of things. It's these patients just would not take the tablets. And I said to some of my colleagues recently at a meeting in Atlanta, well, look, here you have this person that has this disease or disorder or condition for which he's only measuring numbers. He's perfectly fine otherwise. You're throwing all these multicolored tablets at him and saying, take these every day because they're good for you. They're not natural, but they're good for you. And if you don't take them, you're going to die. And he's scared. And then you say to him, yes, some of them can cause erectile dysfunction, but that's not a problem. At least you don't get stiff arteries. And I want you to do this for the rest of your life. My family physician is in the audience, so I probably should not admit this, but I have difficulties completing a course of antibiotics for 7 days. Because as soon as I feel better, I think, good, better equals bug gone, stop drug. But I'm not admitting anything. And so started in Barbados in 2014, the Standardized Hypertension Treatment Project, funded by the United States Center for Disease Control, with several partners, the Pan American Health Organization, our university, CARFA, the Healthy Caribbean Coalition, and last but by no means least, the Barbados government was being instrumental in the Ministry of Health, launched this program for health system strengthening. The program is really very simple. There's a standardized approach to the treatment of hypertension, widespread accessibility of drugs, and it was launched at 2 polyclinics, Edgar Cochrane and Vincent Scott Polyclinic. And then the identification of core drugs. Now, how many drugs do you think we have on the formulary to treat hypertension? 10, 20, 30, not even 30, 40? We have 35 different drugs. 35. Small Barbados. The Americans from the CDC said, you guys must be wealthy. You have 35 drugs available, free of choice. Physicians can choose any. Because it's free, right? But it's costing us. And so the project looked at the development of hypertension treatment algorithms, development of systems to monitor the use of these things. The one thing that gets clinicians scared and healthcare providers concerned is when they have someone looking over their shoulder to see that they're following a protocol. We don't like it. It's like students in an OSCE exam. We get intimidated. So we're more likely to do the right thing. Development of registries to track patients with hypertension, and then of course enhancing non-clinician healthcare providers, nurses, pharmacists, and I'll show you a slide on this coming up, and of course medication access. Awareness, communication, campaigning occurred. We had a lot of stakeholder buy-in, training in master classes, almost as large as this auditorium, and ensuring that drugs were available through the Barbados Drug Service of the 4 key drugs that are used in the project. And we're currently anxiously in our program evaluation phase, and some members of the team are here who I will single out shortly. Now their blood pressure is going to go up. And so the design of a standardized protocol, and this isn't for you to read, although it is for you to read in your doctor's office. The way we designed it is this is at the clinician's desk, so he can see it. You as the patient, it's up on the wall behind his head somewhere in the room, so you can see it. Some of you will also have a copy of it, and you can follow your treatment. You can say, why is it that at step 2 you're using this drug as opposed to this drug? And clinicians and the healthcare providers should not feel threatened by this, because I enjoy these conversations with patients in justifying treatment and why I've chosen X over Y. And this is not to say that protocols are meant to be followed regimentally without any kind of medical knowledge, but certainly what protocols do allow for is for the learner, the inexperienced practitioner, or even the experienced practitioner that needs a reference, something to follow. Individualized care, however, is important. You're not going to say, I want to start you at step 2 on an ACE inhibitor. That's just a class used to treat hypertension. If the patient says, well, I have allergies to ACE inhibitors. No clinician is going to say, but it's at step 2. You need to be on step 2. Get over your allergies. And what about passports? Well, you know the advantages of passports and clearing entry points. I use my Barbados passport a lot traveling through Miami, and I'm always curious as some of the conversations I have with the border control agents. And who knows how things will change if things start trumping up. But you have a patient passport. You have a patient passport, and the patient can have the passport and go to any doctor. You can decide, you know what, I don't feel like going to the polyclinic today. I'm going to go to my private doctor. We're all on the same page. We all know what medication is there, what advice is being given, what advice is not being given. For instance, I could take the passport and say, well, when's the last time you spoke about salt? It says here, it's been more than 2 years. Let's talk about salt today. In the hypertension masterclass, and this slide is really ideal because it shows several healthcare providers. We have a doctor, a nurse, a junior doctor, and a pharmacist all at the same table, and they're working on cases which they didn't know back then were intentionally designed to get them to come around to what I was thinking, but into designing a treatment algorithm to treat hypertension. And boy, the arguments in that room to patients might have been alarming. I can't tell you all of them, but some included things like, I would say at the table to the nurses, do you think you're involved as much as you could be? And the nurse would say, the doctor would respond first, of course, she does my blood pressures. You know, when I'm inside, she does 3 blood pressures before the patient comes to me. And the nurse will pull me aside and whisper, and he doesn't even look at them. He just repeats it. Because there's magic in the doctor's reading, isn't there? We think that. It's only a blood pressure if it's done by a doctor in a white coat. And so the GSHTP team here, and I see Dr. Jamario Skeet at the back, who's part of the team. Jamario, where are you? I told you I would embarrass you. There you go. And members of the US team here with us at the Errol Waldron, almost said Henry Fraser Clinical Skills Building, where we had a site visit during the master class. And I'm pleased to say that our medical students, this is medical student Shay Stewart, who's a final year medical student now, and who assisted a lot in data collection. So the university played a major part in this project. It didn't make a substantial one-off donation, but it played a major part in the management of hypertension and changing a wave of change of hypertension management that will likely occur over the next year. We are not ivory towers. And so the SHTP is the academic home of the university is the academic home of the project. We are a regional institution, and therefore our tentacles can spread. And so this news of how to manage blood pressure is not limited to Barbados, but through the university, this can spread to other campus sites and non-campus sites. The open campus, and the deputy principal can correct me, is the largest campus. It has quite a lot of students registered at different campus sites. And of course, we train medical students and residents in this new way of patient engagement and use of protocols and measurements and registries, providing evidence-based updates to providers. Okay, so finally, here are my take-home points for the evening. There are lots of them, but they're all important, so just bear with me. Barbados at 50 years exemplifies the changes in disease patterns observed in all developing countries, from infectious diseases to NCDs. We're not unique in that respect. The NCD burden, however, on its current trajectory could signal catastrophic outcomes for a small island developing state like Barbados. Cardiovascular diseases are a major part of the NCD burden, of which hypertension is the greatest contributor to death and disability. Regardless of the cause, blood, salt, or tears, the disease burden is higher in Black African people. The management of blood pressure, therefore, involves establishing methods to improve robustness of the diagnosis out of the office. And home blood pressure monitoring, in red, using a validated monitor, allows for trends to be treated or to be taken. One-off readings, therefore, should not be used in the office to determine how you're going to be treated. And I say this to patients all the time who have forgotten their home monitor sheet. I said, well, we have some readings here in the office. They might be reflecting your blood pressure, or they might not. Therefore, I could be over-treating you, or I could be under-treating you. No patient ever feels comfortable hearing those words. So home blood pressure monitoring is important. So all persons with a blood pressure, which coincidentally is everyone in this room, should monitor their blood pressure. And people with hypertension should do this more often. If you are on medication or not, you should get yourself in a routine of having a consultation with your doctor, coming with readings to the consultation. Treatment includes both lifestyle changes and drugs, blessed or unblessed. And strategies to improve the management of hypertension include methods to strengthen healthcare delivery systems. The Standardized Hypertension Treatment Project is one such model. The Cave Hill campus must therefore continue to lead in research and policy in the management of hypertension in Barbados at 50. And so my wish list for an independent Barbados 50 years old is that everyone, and you've proven by your presence here, everyone is aware that hypertension remains a less attractive subject. It doesn't capture the headlines like Zika virus, but it's a more deliberate danger to our society. Home blood pressure monitors are monitoring, I hope, will become contagious. And as we proclaimed from this very hill, one university graduate in every household, perhaps we might have one blood pressure monitor in every household as well. And finally, the campus community will lead the way in this initiative of home blood pressure monitoring for staff. And here's my plea for funding. With the 2016 KFIL CATCH, Campus Action to Control Hypertension program, which will soon be launched this year. So I invite you to catch the fever here at KFIL at 50. Happy Independence to you all, and thank you for being an attentive audience. I am much obliged.
Thank you, Dr. Connell, for that comprehensive and interesting and exciting lecture. Now, I was looking around for Ms. Christiane Walcott, who is going to moderate question time. Ms. Walcott, oh, yes, he's going to check the Twitter feed. I just confided to Kenneth today, I've never been on Twitter or on Facebook. I'm some of the dinosaur age, but I'm pretty computer savvy, etc. But question time is going to be moderated by Ms. Christiane Walcott, our administrative officer. Christiane came on faculty when the then professor, well, Henry Fraser, had envisaged the faculty and was trying to get it constructed and put together. And she was instrumental in assisting in getting us going in this building being constructed, etc. But before Christiane moderates, I know she's quite strict, I'm going to get in a question or two.
One question.
Okay, one question. You had a slide, one of the earlier slides said 30% of persons had controlled hypertension. And
Less than 30%.
less than 30%. I thought it would be less than that, yes. And I just wondered how we're going to get that number up. And the second question is, when every household has its own blood pressure monitor, Series 7 Omron, or 10 by that time, and everyone is taking their blood pressure twice a day, 2 readings morning, 2 readings afternoon, and then we'll have an app on their phone one day that will tell them what medication to take and what to do. And wouldn't you go out of business?
I will never go out of business because the dean will keep me busy. So how are we going to get the control rates up? I think we've understood in hypertension world that the secret is not behind creating more expensive, attractive drugs, but it's really healthcare, health system strengthening. How do we get physicians to follow standardized algorithms? How do we even measure our success? For instance, at some of our polyclinics, there was no registry, so we had no idea even how we were doing. When I asked some doctors in the master class, what percentage of your patients are controlled? They had no idea, but yet they're seeing patients with hypertension every day. So we have to measure it. And we have to make cheap evidence-based drugs. Someone just tweeted. Cheap evidence-based drugs available, which is not a problem in Barbados because we keep expensive non-evidence-based drugs available as well. And I'm ashamed to say that one of the most prescribed drugs used in Barbados in the public setting is the most expensive. But it has nothing to do with marketing, although the marketing flyers are all over the polyclinics. And your second question is, well, you know, what about your job? Well, the doctor now has transitioned into another role. And yes, Peter Adams, I listened to your family medicine consultation lectures as a student, so I'm going to throw this back at you. The whole relationship now changes from paternalistic, I'm using your words, to coaching. And sometimes in the consultation, I feel like a coach. It's like, oh, you know, you're doing really good now. But I noticed that your nighttime or your early morning blood pressures are slightly higher. I think we should dose the Norvasc. Scrap that from the recording. I'm not allowed to use trade names. The amlodipine at night. I can say things like that. Or I don't think you're coping very well with the ACE inhibitor or those kind of things, we can have a discussion. And I don't mind patients coming to me with all the evidence. In fact, sometimes my discussion is on the face of an iPad screen with the latest thing that's on CNN or some other program. But I don't mind having those discussions. So the doctor's role has to change. And this is something that healthcare providers are probably not comfortable with, because we've now lost control of this measurement that we created, and only us can measure it. And now we're saying, well, you measure it and bring it to us and let us discuss this. And I use statements like, how are we going to get you to decrease your salt? Or how are we going to overcome this challenge with you only getting one reading in a week? Things like that. And I take pleasure in my patient's success. So it's really the change of the physician's role. Physicians, we're here to stay. We will always be needed, but our role will change from the paternalistic model to the coach. Thank you, Dean.
Thank you, everyone. Thank you, Dean. I just would like to take this opportunity to first congratulate Dr. Connell on his excellent presentation. And some 85 plus slides later, I'm sure that we are all the more edified for it. So we will get straight into your questions or your comments, and we will take all of them that we can within reason. I will give Dr. Connell the opportunity to scroll through any Twitter feed and so that he might like to share with the group. If you're interested in making a comment or a question, I ask that you just approach one of the aisle mics, and we will signal to you when you're ready to do so. Yes, sir, we have our first question.
And I'm very nervous about this question because the gentleman approaching the microphone had the challenge of teaching me mathematics at Lodge.
Okay.
Yes,
Dr.
sir.
Connell, in your presentation, I noticed that you had blood, salt, and tears.
Mm-hmm.
And I'm wondering whether you thought that salt was a major contributor to hypertension, when there are other aspects, or what you call risk factors, such that also contribute to hypertension, such as stress. Mm-hmm. We all live very high-stress lives.
Especially deputy deans.
As well as having insufficient exercise. Mm-hmm. So I wonder if by zeroing in on salt, you figure this was the main risk factor as opposed to some of the others.
Right. That's an excellent question. And as I hinted during the presentation, so salt raises everyone's blood pressure, whether you're salt sensitive or not. If you are salt sensitive, however, and statistically in this room, half of you are, take my word for it, half of you are salt sensitive, then your blood pressure response to salt is going to be extremely high. And so salt reduction is going to be even more important in that group of individuals. Now, as to say, whether to say that salt is the major determinant, it's hard to say because there's so many other factors playing a role there. Your genes that are switched on, the same genes that are switched on to cause salt retention, are probably affecting other parts of your cardiovascular system and putting you at risk as well. So they're causing the stiffer arteries by other mechanisms which are contributing to hypertension. But yes, if you want to choose a lifestyle thing to target, it's salt. And certainly, we do it as doctors a lot in hypertension. The number one drug that's used in the Black Caribbean patient is a drug that gets rid of sodium. And that's because the problem is really sodium related. So a diuretic is used as a first-line agent. And we've been doing that for years from I almost said the Henry Fraser era, but I wouldn't. So salt is at a central role, and limiting it and drugs that remove it certainly affect blood pressure more in our population. So we have one, is it a twit or a tweet? A tweet. We have, maybe it's both. So we have one tweet, and the tweet is, I'm not going to read the first part. I can't read the first part. But the second part states, how realistic is it to do a blood pressure every day? And I recognize that's a challenge. I mean, that's a huge challenge. And so I say things to patients like, well, you have a cup of coffee every day, you brush your teeth every day, turn the car ignition every day, get into a routine so that this is so second nature, like the patient that just slips off of bed and presses the button and it awakes her. It has to become second nature. And you have to be regimental and meticulous about it. Don't just kind of say, oh, it's time for the blood pressure. Let me just quickly slap this cuff on, whether it's on right or wrong, plug it in and just press and lay back down. He said twice a day, he never said how. You have to be meticulous about it. The same chair, in the same room, almost the same time, so that you're comparing apples and not apples and oranges with salt. So this must be a conspiracy, because I have another one of my teachers here who taught me physics. So hopefully his questions are a lot easier than they were then.
Dr. Connell, I'm just wondering, can you give me some more insight to the whole medication process? Because apparently some medications work and others don't. Can you be in the field?
You want me to talk about the drugs?
Yes, then.
That's a question you never ask a clinical pharmacologist at 9 o'clock. But so the drugs act differently. The ones that are used commonly in our population includes drugs that get rid of sodium. I've already touched on that. The other problem with hypertension with these stiff arteries is that trying to get the arteries to relax. And so drugs like calcium channel blockers, some of you are on Norvasc or amlodipine or another calcium channel blocker. The beta blockers that slow the heart down and also might also be associated with other side effects such as nightmares and I almost don't want to say erectile dysfunction because that's a major barrier, but they're not used early in the management. And so the trend in hypertension is really to use several drugs at lower doses rather than one drug at a high dose, and that's how we get around the side effects. The patients in the resistant hypertension clinic, for instance, are on average like 4 to 5 drugs. They're on a lot of drugs. Well, when you think about it, they have to be on at least 3 drugs to make it into the clinic. But they're on like 4 and 5 drugs, and they're all, because I have to take the time to do it, because I know taking 4 tablets is, you're going to say, let me just take drug 1 and 2 on Monday and Tuesday. 3, 4, and 5, I'll take on my salty days. And I have a hard time convincing patients why you need to take all of them, because they're all acting together to lower your blood pressure. And the reason there's so many tablets is because a higher dose of one tablet may put you at risk for complications and side effects. So in response to your question, the drugs are given as a cocktail. The reason a cocktail is used is to reduce side effects. The drugs all act to help each other to work to either remove sodium or relax the arteries. And I want to leave this point with the audience as well. It is actually safer for you not to take any medication than to start and stop medication in hypertension. Your brain does not appreciate that. And it tells you that by having a stroke. If you take the blood pressure medication on Monday, skip Tuesday, Wednesday, and then Thursday, your brain can detect those changes, and those changes can be lethal, right? So I either say to patients, either be consistently non-adherent or be consistently adherent. Don't do the on and off experiment. Coincidentally, the home blood pressure monitor allows you to experiment, doesn't it? It allows you to try your, moringa? All sorts of home remedies, and you get to see, well, if I stop the tablets, yes, I know he has a vested interest because he's a doctor, he has to prescribe. I mean, he's going to look kind of stupid giving me an empty prescription. He has to prescribe. Let me just stop them and see if it really is working. You see your blood pressure trending up on your monitor. It's not my monitor, it's your monitor. And you also get to see the effects of all the other tablets that you might be using that you're not admitting to over the counter. And one common culprit, for instance, are the painkillers, the NSAIDs that people use. It's the number one cause that I certainly see in the clinic of patients with drug-resistant hypertension. They're on NSAIDs, they're on chronic painkillers like Voltaren and Cataflam. And sometimes stopping the painkiller which causes fluid retention, can reverse or can minimize the effects of hypertension. I'm very pleased to see a student approach the microphone.
Thank you, Dr. Connell. Coming from a public health background, I'm more than eager to ask you, I know your lecture stressed heavily on management, but I'm curious as to know what are the public health strategies? Because you said 60% of the budget is allocated to address hypertension alone, and more than, at least 35 drugs are available. So we have the tools, yet the problem still exists. Is it more in management? How are we dealing with it as a preventative measure, where we believe and we always preach that prevention is better than cure? What are the public health policies in terms of addressing hypertension? Can you answer me or advise me on that, please?
Sure. You see, you get to ask me a question now. So the public health issues are quite simple. They involve health system strengthening. And we are probably now at a point at 50 years in Barbados where we have a highly educated public. Medical information is not secret. You can go and Google it. I have patients Googling in the office, although they claim they're checking blood pressure trends. They're checking to see if that drug is FDA approved. And so you have the information. We now have to, as healthcare providers and as future providers like yourself, we have to decide on how we're going to manage a chronic disease. All of us have to be on the same page. We all have to be following some kind of hymn sheet, because Canon Burke is here. And we have to measure our success. It makes no sense saying, I only cost the clinic $20 last week and none of your patients are controlled. You have to measure it. So aside from the usual public health campaigns on television and the ads and all those other things, we as healthcare providers need to take responsibility and shift the blame from the patients over to our side. What can we do to make the healthcare system stronger to manage these patients?
Thank you.
So question from Dr. Anne-Marie Cruikshank, one of my mentors. My first arrest in A&E was with Dr. Cruikshank. Thank you, Anne-Marie, for attending.
Thank you, Kenneth, for a fantastic presentation. Question. A lot of my patients are elderly, according to WHO definition, more than 65, and Prof alluded to the number of patients with hypertension over 60. Do we want to control elderly patients' hypertension per se, or can you give us a range in which we would like our elderly patients for their hypertension management?
I think that's a very important question, and I'm glad that someone in the audience has asked it. So recently in hypertension land, a study came out called the SPRINT trial that suggested that we really should be getting blood pressures even lower. And as you probably realize from my slide, this moving target, if you lower the target lower, then the range also shifts lower, and therefore patients are at risk of getting lower blood pressure. As I said, in Cambridge, a blood pressure of 0 is bad. So the elderly patient, you probably need to be a bit more cautious, and the guidelines are relaxed for that. For instance, the guidelines coming out of the US, most of them recommend 150 on 90 for the elderly patient. For the very elderly patient, you might go even higher. There's a problem. So there's a third problem with measuring blood pressure, and that's the measurement that's taken at the artery here, the brachial artery, is not, as we get older, an accurate reflection of what's happening at the artery leaving the heart. But really the risk of stroke is really related to the artery, the pressure in the artery at the heart. So we're not even accurately measuring the central pressures in the elderly. So you think you get a reading of 160 on 90, but the central pressures are a lot lower. Now, I always do this test in the office, and I do the Get Up and Go test, which is a test that rheumatologists do. And if I think the patient has a fall risk, for instance, then I'm certainly a lot less aggressive. I would do a 24-hour monitor on them and look for periods of hypotension or when they're at an increased risk. Obviously, any reported incidences of falls should be taken seriously. You don't need to be as aggressive with the elderly patients, but elderly patients need to be treated. And so Many of you know that I'm a strong advocate of geriatric care, and age is not an excuse not to treat blood pressure, but certainly the protocols and the targets are relaxed for the safety of the patient, for the safety. So I would recommend, for instance, your patient who is, say, over 60, spend some time talking about fall risk, spend some time talking about any of those orthostatic type symptoms and lethargy. If you're still not convinced, do a 24-hour monitor. And then make changes to the medication. I also tend to dose drugs, except diuretics, of course, in the elderly patients at night because it does assist with their nocturnal fall in blood pressure. Thank you.
Thank you.
Thank you, Dr. Connell. I think we'll close our... Oh, Sir Henry. Sure.
He could have come in.
Oh, he could have. Go ahead.
Thank you very much. Let me begin, please, before I ask my question, by saying that the greatest satisfaction for any teacher or mentor is to see his mentee or student excel to the point where he does a better job than the teacher. Thank you.
Thank you. Thank you, Henry.
But although Kenneth, I explained to the audience that the name Connell meant a strong wolf, I wonder why you avoided the risk factor and the relationship with obesity if it's just because it's become suddenly a hot potato in the public discussion. Mm-hmm. And therefore, I would ask you to comment on obesity, because what is not generally known is that the loss of 10 kilograms body weight will take your blood pressure from the high risk to the medium risk, from the medium risk to the moderate risk, and so on.
Yes.
So I just wondered if, although you're a strong wolf, you were afraid to raise the topic of obesity.
Well, the dean covered it so well in his decanal lecture that, why go on to obesity? But obesity, yes, is an issue, and weight loss is associated with lowering of blood pressure for the obese or overweight patient. So if you have a normal weight, losing weight is not really going to get your blood pressure down. And I have seen a small percentage of patients who sometimes, I'm almost afraid to say this, get to come off at least one drug because they've lost some pounds. And although I've said to them, you need to be on these 2 drugs for the rest of your life, they proved me wrong by losing some weight. This doesn't happen very often. And you don't have to be obese to have hypertension either. Some of my patients are very slim and fit looking, and they have severe resistant hypertension, but obesity is a contributor. And it's part of this Muskateerian family of hypertension, diabetes, and high cholesterol in the metabolic syndrome. We have one last question from Shea Corbin.
What's going on?
If you could approach the microphone, please.
Just
He doesn't even need it.
Dr. Connell, just following what you were just saying, are these slim and fit patients who look slim and fit, are they actually slim and fit? And when we're talking about obesity and weight loss, are these people losing weight by exercising or by other means? And how much effect does exercise have on hypertension? Is exercise prescribed, and to what extent? Thanks.
Yeah. So to answer your questions in reverse order, the exercise prescription is commonly used in hypertension, and I have written some of them. Some of the patients look at me like, you can't be serious. I mean, you're going to honestly write this on a prescription pad. And I hand it to them because, again, it's an intervention, and I want them to take it as a serious intervention. Exercise can lower blood pressure. Exercise has a unique advantage as well because it releases all these feel-good substances, the endorphins, and so you feel good even from exercising, even if you don't lose the weight. Now, how you lose the weight is, as you're suggesting, is also important as well. So the fad diets, for instance, may do more harm than good, and you may find that you're losing weight but retaining fluid as well, and that might cause an elevation in your blood pressure. In terms of physical fitness, now, some of the patients that have resistant hypertension, they're very fit. In fact, 2 of my patients in the clinic are gym instructors, and they're health fanatics. They come and they tell me, you need to work out some more. They're really health fanatics, and they have very high blood pressures, and they're adherent with the medication, they're taking it home. Then they say to me, well, why is this happening to me? And it comes down to what we discussed for the evening. It's your genes. Once those genes are switched on, and if there's anyone in the audience who knows how to get them switched off, just tell me, because that could make our life a lot wealthier. If once they're switched on, they're on. And you could do all the exercise in the world and lose all the weight in the world. Well, not take all the medication in the world, but once they're switched on, they're difficult to treat. And that's the type of hypertension that is quite commonly observed. It's in our genes. Thank you.
Thank you, Dr. Connell. And as he's already pointed out, the conversation does go on. You can get him at #hypertension@5050@Cave Hill on Twitter, or at the email address that's published above. So thank you once again, Dr. Connell. Back to you, Dean.
Thank you, Christiane. But all good things must come to the end. And before we move into the vote of thanks, I just want to remind you that this is a series of lectures. It's just not a one-off lecture. And it will be going right up to November. When November arrives, we might have been having such a good time, we may want to continue, who knows. I was listening to Sir Henry in the Senate last night on the radio, and he was saying that, you just can't have one advertisement and expect the room to be full, but we only had one advertisement in the papers, and we pretty much got a full room. Of course, Kenneth's quite, he's been on TV as well and on radio. But I want to remind you of the upcoming lectures. All the lectures are going to be on Thursdays, but at different times of month. So next month on March the 10th, and they're at the back of your program, so you just keep them, and you can always refer back to them, is Glaucoma, the Silent Thief of Sight. So we had the silent killer, now we have the silent thief of sight. And that's going to be given by Dr. Dawn Grosvenor, who is our lecturer in ophthalmology and associate. She's in the audience somewhere. Oh, yes. A class of 2000 graduate, yes. She's Twitter savvy and Facebook addicted, probably. And she's an associate consultant at the hospital, and she's a specialist in glaucoma. And then on April the 21st, we have Diabetes in Children by Dr. Michelle Lashley, well-known pediatrician. The vote of thanks will be given by Dr. Colette George, a lecturer in internal medicine. Colette is an endocrinologist, and I'm sure she would like to spend most of her day treating diabetes and thyroid disease. But unfortunately, when she's in service in the hospital, she spends a lot of her time admitting that 70% of people who are not controlled in their blood pressure and having to deal with high blood pressure. Dr. George?
I didn't realize when I came in it was such a full audience. But on behalf of the UWI 50th anniversary celebration, I'd like to thank, our Dean, Dr. Adams, for his role as Master of Ceremonies, Professor Emeritus Sir Henry Fraser, for giving us some insight into Dr. Connell's development as a physician, but also for acting as his mentor. And I'm happy to see that you didn't just pass on the hypertension baton, but also the oratory skills. I'd like to thank, of course, the star of the night, the handsome wolf, Dr. Kenneth Connell, for a captivating, entertaining, and well-delivered lecture. Dr. Connell did not tell you, but I know he was talking about me when he talked about the colleagues who like salt. So we have this ongoing battle about salt, and because of that, I also have to thank Canon Burke, who is Dr. Connell's spiritual director. And one time when I wrote to Dr. Connell an email just to kind of rile him up, telling him salt is important, it's the salt of the earth, Lot turned into a pillar of salt, he forwarded my email to Canon Burke, who replied. So thanks, Dr. Connell, and I nominate him for the university's next public orator. To Christiane Walker, who works tirelessly behind the scenes, to the technical support team, and of course to you, the audience, for your participation. And attendance at this rather long lecture. So travel safely. Good night.